My dear students, in this lecture, I am trying to give you some glimpses on how to approach CLABSI. CLABSI, we all know, is a central line associated bloodstream infection, and it is one of the frequently encountered problems in any ICU. And unless we approach a very scientific and evidence-based approach, we will not be able to prevent and treat CLABSI. And this is a very important subject in for the trainees, and I hope that it should clear many of your doubts. Let us start with the case. A 35-year-old male polytrauma patient presents with head injury, fractured ribs, pneumothorax, and also pelvic fracture, undergoes surgery and is shifted to the ICU. On third day post-operative period, patient develops high-grade fever, chills, redness and swelling at the site of right IJV cannulation. And on examination, patient is found to have tachycardia, a borderline blood pressure towards hypotension, tachypnea, saturation with normal room air. Now, the patient was already on peptides, metrogel, and clindamycin, and the investigation shows a raised TLC with predominant neutrophils. So, as a norm, the cultures are sent, the antibiotic upgraded to meropenem vanco in place of peptides clinda. And the question is that what is the likely diagnosis? And it is very clear from the case itself that there is no doubt that we have to think about the central line associated bloodstream infection in this patient. Now, the question is that what is CLABSI? CLABSI, as you know, is a surveillance definition used by the CDC. Why it is surveillance? Because it is used to monitor the behavior of the activity. When we say that we surveillance, then we need to find out or need to check or need to ascertain that what is not working fine, why there is CLABSI. So this is something which is important because CLABSI is not for therapeutic definition. It is not a clinical definition. It is a surveillance definition. And as per the surveillance definition, it is defined as a recovery of a pathogen from a blood culture. And this blood culture can be a single blood culture for an organism which is not commonly present on the skin, or two or more blood cultures for organism which may be present commonly on the screen. This is because there are some normal common cells, and isolation at only one point of time may just indicate contamination and not an infection. So in case of commonly occurring organisms, there should be a minimum of two, whereas for uncommonly occurring organisms, even one single episode of blood culture isolation will conform to the surveillance definition of CLABSI. And it is important to remember that this infection cannot be related to any other infection the patient may be having or hibernating, and must not have been present or incubating when the patient was admitted to the facility. So if the patient is already having an infection, so that needs to be excluded because that is not a part of CLABSI. Then we need to differentiate then how different is CLABSI from CRBSI or catheter-related bloodstream infection. Although they are often used interchangeably, the two definitions are different. The concept behind these definitions are different, and the strategies are to a large extent similar, but their importance is different. So for catheter-related bloodstream infection, the definite diagnosis requires one of the following. And mind that this is a clinical definition, that one, it can be either isolation of the same pathogen from a quantitative blood culture drawn through the central line and from a peripheral vein with the single bacterial colony count, that is SBC, at least threefold higher in the sample from the central line as compared to that obtained from the peripheral vein. So if it is so, it satisfies CRBSI. Or if same organism is recovered from the percutaneous blood culture and quantitative, that is more than 15 CFUs culture of the catheter tip, then also it is CLABSI. Or if a shorter time to a positive culture, that is 2 hours earlier in the central line sample than the peripheral sample, So this is that is a technical term used for this is called DTP, or differential time to positivity. If it is more than 2 hours earlier in case of central line sample than the peripheral sample, then also it is a case of CRBSI. Therefore, you have to remember that whereas CLABSI is probably more easy to recognize and identify and define, CRBSI may not be possible always in all setup unless and until you have sufficient methods to collect both peripheral and central uh, blood and compare on the make a quantitative count. Now, what is the pathogenesis of CLABSI? CLABSI, as we know, it is the infection is in the central line. And we know that central line are the lines or the cannula which is inserted into the veins which are close to the heart or in direct communication to the heart, and for which this infection can easily go to the heart from where they're distributed elsewhere in the body. Now, for the for simple purpose, if you want, for the sake of clarity, the jugular veins, the subclavian vein, the femoral vein, the iliac vein, the brachiocephalic vein. So these are the common veins which are regarded as central vein because they go straight into the heart. So how this infection spreads? This infection can be spread extraluminally, that is, pathogens migrate along the external surface of the catheter from the skin entry site, and then they spread through the vein to everywhere elsewhere in the body. Now, this extraluminal spread that is occurring from the skin directly along the catheter, not entering the lumen, this usually occurs within 7 days of insertion. Second, there can be intraluminal spread. Intraluminal spread occurs because of hub contamination. We know that the hub is a very potent site where the bacteria can thrive and grow. And from this hub, they can migrate along the internal surface of the catheter and spread to the blood, reach the heart, and then get distributed everywhere else in the body. So this commonly occurs after 7 days of cannulation, and it is causes intraluminal colonization followed by infection. The third cause of pathogenesis can be a secondary bloodstream infection where there is bacteria from another source in the body, like maybe a urosepsis, maybe pneumonia, from where it reaches the blood, and via blood it reaches the central vein and contaminates or infects the central line, giving rise to CLABSI. And fourth cause, of course, is because of infused contamination, like if there is introduction of pathogens from the intravenous fluids that patient is getting administered through the catheter system, then also there are chances that it can cause CLABSI. Now, there are certain risk factors for CLABSI. So these risk factors can be broadly categorized as those which are provider characteristics, device characteristics, and patient characteristics. Among provider characteristics, if you have an emergency insertion, that has a greater likelihood of CLABSI than elective insertion. Excessive device manipulation puts that risk because every time we manipulate, we increase the chances of introduction of infection. If there is incomplete adherence to safe insertion practices like no chlorhexidine, no proper hand hygiene, etc., then there is more chance of CLABSI. Failure to remove unnecessary devices. When the device which has been inserted for a particular reason remains for time period where it is no longer needed, so mere retention of that device increases the risk of CLABSI. Low nurse to patient staffing ratio can also overlook some of the manifestations giving rise to CLABSI. So these are the provider characteristics. Among device characteristics includes the site of insertion. We know that femoral venous site cannulation carries a higher risk of CLABSI over jugular or subclavian. Number of lumens, if the more the number of lumens, more the chances of CLABSI, because each of those hub can become contaminated with the pathogenic bacteria, which can spread intraluminally and get distributed elsewhere. The indication for use, like total parenteral nutrition, chemotherapy, etc., we know that the medium during total parenteral nutrition can be a good culture medium for bacteria to thrive upon. And when such practice is adopted, cleanliness is not maintained, then also it can increase the risk of CLABSI. And the third risk factor, the patient characteristics like the immune compromised host or the neutropenic hosts, needs no explanation. They have greater chances of CLABSI. In severe skin burns or protein calorie malnutrition, there also the immunity is compromised, so there is more chance of CLABSI. And prolonged hospital stay prior to the device placement, because that causes already pre-existing colonization, and after the device is inserted, those colonies of those organisms can spread along the vein during insertion and subsequently causing a CLABSI. How to diagnose CLABSI? The clinical manifestations will vary depending upon the severity of illness. So not all patients will be very sick. Some of them will be moderately sick. Some of them will be mild. And it is important to remember apply our mind to make a diagnosis. Fever and chills are the commonest manifestations, but they may be masked if patient is immunocompromised or an extremes of age, because they will not be able to mount the kind of inflammatory response which is required to manifest these symptoms. So they may have atypical presentations which may be altered mental status, hypotension, fatigue, lethargy, and so on. We know that exit site examination, we know that there are certain catheters which are tunneled catheters. Commonly use the non-tunnel catheters, but if we use tunnel catheters, we create a tunnel in the subcutaneous space and the catheter is lodged in that space. So there is one entry point and one exit point. So exit site examination to look for signs of inflammations of tunnel catheters with inspection and palpation of the subcutaneous tract is essential. And also for long-term catheters, difficulty in drawing blood or poor flow, they are also indicative of inflammation and CLABSI. So what is the microbiological diagnosis? Blood culture is the most crucial step towards diagnosis. CBC, ciliary electrolytes, LFT, KFT are all necessary to assess the severity and the presence or absence of comorbidities. In suspected cases, paired blood cultures, one from central line and peripheral line, must be drawn and labeled accordingly before being sent to the lab. In case of poor peripheral access or when unable to obtain a peripheral sample, two or more samples must be drawn from the different lumens of a multiple lumen central line. So if paired blood culture is there, the peripheral vein puncture and catheter blood cultures have failed to identify the CLABSI, the catheter should be removed and the tip should be sent for culture. Now, what to see in case of tunnel catheters? As I told, you have to see two things. One is the exit site infection. Exit site infection are the signs of inflammations which are confined to an area which is typically less than 2 centimeter. And this is surrounds the catheter exit site. And there is also presence of an exudate which proves to be culture positive. So this is called exit site infection. And another infection is called the tunnel infection. As I told before, we create a tunnel or a space in the subcutaneous plane where most of the catheter lies, and the catheter is unexposed to the skin around the surface of the body. Now, tunnel infection, this inflammation extends beyond 2 centimeter from the exit site. In exit site infection, it was typically less than 2, and here it is more than 2, along the tract or cephalate towards the vein entry site or extending beyond the cuff. Typically, it is associated with pain and tenderness along the subcutaneous tract and culture positive exudate at the exit site that may be felt by palpation also. So these are the two differences in cases of tunneled catheters. Now, how to treat CLABSI? Empiric therapy should be based on the most likely organism, host factors, and overall clinical picture. In general, coverage for common gram-positive and gram-negative organisms should be made. The local prevalence and antimicrobial susceptibility of patients in institutional antibiograms should be considered. If vancomycin is used, IV vancomycin, if MRSA is prevalent or cephalosporins for MSSA can be enough. If MRSA with MIC is more than 2 for vanco, or in case there is VRE, then we can look for daptoteco, linezolid or clindamycin. Now, gram-negative coverage is also the important because most of the infections we develop in our ICU is gram-negative infections. For gram-negative coverage, a combination of BLBLI and aminoglycoside is preferred. Cefepime or carbapenem with or without an aminoglycoside is administered for high risk of resistance. Echinocandins are preferred or kept on reserve for suspected candidemia. When to remove the catheters? All non-tunnel catheters should be removed promptly, sometimes even before it is proven with the criteria that it is CLABSI, but the clinical suspicion is high. So if the clinical suspicion is high, you have to remove. In case of long-term tunnel catheters, the removal must be done in presence of tunnel infection, as I told you, more than 2 centimeter below the exit site infection, and blood cultures that have been positive for more than 72 hours of appropriate antibiotic therapy, persistence of symptoms more than 36 hours, or severe sepsis, shock, and metastatic infection, difficulty in clearing organisms like Staph aureus, Pseudomonas, or fungi, and recurrence of uncomplicated CLABSI when salvaged for difficult access. You have to remember that only for long-term catheters, salvage in the form of systemic therapy coupled with antimicrobial lock, that is heparin plus high concentration of antimicrobial agent that is selected based on susceptibility results, can be attempted in limited instances. When should we discontinue the therapy? What should be the duration of therapy? Most patients with uncomplicated CRBSI without any evidence of endocarditis or metastatic infection in the absence of risk factors or for hematogenous spread, like through hardware, immunosuppression, and negative blood culture, 72 hours of catheter removal following approach for IV antimicrobial therapy is recommended. For Staph aureus, it is 14 days in the absence of endocarditis. Coagulase negative staph, it is 7 days. Enterococci and gram-negative bacilli, it is again 10 to 14 days. And Candida, it is 14 days in the absence of retinitis, and it is higher with more than a month in the presence of retinitis. Now, how to prevent CLABSI? The study which has been most important study in this regard has been the Keystone Bundle intervention. Now, we know that bundle is a structured way of improving process of care and print outcomes using a set of evidence-based interventions at the same time. Now, this Keystone study, which was a statewide initiative in Michigan to prevent CLABSI, was undertaken in 103 ICUs and was launched in 2003 October, made use of this bundle of best practices. And that included hand hygiene prior to catheter insertion, use of maximal sterile barrier precautions, use of alcohol containing chlorhexidine for skin, antisepsis before insertion, avoidance of femoral site, and also removal of unnecessary catheters as early as possible. So the whole of these guidelines has been divided into two, that is preventive or prevention guidelines during insertion, which includes hand hygiene by washing hands with soap, water, or alcohol-based gels or foams. Gloves, of course, do not prevent the need for hand hygiene. Strict aseptic technique using maximal sterile barrier precautions to be undertaken. 2% chlorhexidine skin preparations for disinfecting or cleaning the skin before insertion. USG guided by an experienced provider for placement of or to circumvent mechanical complications and reduce the number of attempts. So the only way the ultrasound helps is by reducing the number of attempts. Avoid the femoral vein for central line placement and prefer the subclavian vein when possible for non-dominant or the non-tunnel catheters. Promptly remove any central line which is no longer used. Replace central lines placed during an emergency as soon as possible or within 48 hours, and always use a checklist. Similar guidelines exist during maintenance also. During maintenance, disinfect the catheter hubs, injection ports, and connections before each time before accessing the line. Replace administration sets other than the sets used for lipids or bloods products every 96 hours, and assess the need for central line daily so that it can be removed at the earliest when it is no longer necessary. Now, these are the results of the keystone study about which I just mentioned, and you can see how adoption of this practice can bring an effect and how the overall uh, overall organisms that are obtained can get reduced. If you look into chlorhexidine versus povidone-iodine, a lot of studies were there, and this meta-analysis clearly spells out that chlorhexidine is superior and it reduces the risk of catheter-related bloodstream infection as against povidone. There is also some role of socio-adaptive interventions, and that includes clinician education, designated physician and nursing team leader for the rounds, central line cart in each ICU, insertion checklist, nurse empowerment to stop procedure if best practices are not allowed, adherence to best practices, and to frontline staff, feedback process provided regarding the rates of CLABSI. So these are the two tiers of CLABSI prevention practices. The first tier is to perform needs assessment with CLABSI, GPS, and TAP strategy. And in those, we will have to ensure the proper growth. So in this, we will have to understand that there are two tiers. The tier one is the standardized, the supplies, procedures, and processes. It has 5 steps to assess the appropriateness and need for CVC, select appropriate site of insertion, avoiding the femoral site, ensure proper aseptic insertion with maximal barrier precautions and ultrasound guidance, ensure proper care and maintenance of CVC like proper hand hygiene, adequate staffing, disinfection of character, and optimize prompt removal of clinically unnecessary central venous catheters. The next tier is of enhanced practices, which need performance needs assessment with CLABSI, GPS, and TAP strategy, where we conduct multidisciplinary rounds to audit for necessary or continued CVC use, feedback CLABSI and CVC utilization matrices, observe and document competency and compliance with CVC insertion and maintenance, use additional approaches as indicated by risk assessment, and full or mini root cause analysis of CLABSI if it so occurs. So my take-home message would be that despite a lot of progress, CLABSI remains a costly, morbid, and lethal condition. Prevention of CLABSI should include both technical and socio-adaptive elements. Guidance using these strategies will be provided in a tiered format, tier 1 and 2, so that to help us implement quality and CLABSI prevention interventions. Thank you very much.